Before we get started, I want to just introduce myself and introduce the Sorenson Center, and then I'll introduce our presenter. So this is the webinar, A Response to Disability and Approach to Adjusting. My name is Dakota Pond, and I'm a certified social worker at the Sorenson Legacy Foundation Center for Clinical Excellence. I will be the moderator for today's webinar. And then before we get started, we'd like to respectfully acknowledge that Utah State University is a land-grant institution, and our activities throughout the state of Utah take place on tribal ancestral lands. These lands have been carefully stewarded by the Goshute, Navajo, Shoshone, Paiute, Ute, and Mountain Ute tribes. We offer our respect and recognition to their elders past, present, and future. An introduction to the Sorenson Center. We have various clinics and professionals who provide services like early intervention classrooms, hearing and balance services, speech language therapy, behavior support services, housing and financial counseling, psychology, marriage and family therapy, psychiatry. We have an integrated assessment team. We have Michael, who has joined us and is now doing clinical rehabilitation counseling. So we've got a lot of different services, and if anyone has questions, my contact info is there at the bottom of the slide. If anybody has questions or anything like that about the services, you can always feel free to add those into the chat as well. So this webinar, like I mentioned, is being recorded. During the presentation, we would appreciate if you remain muted. You can send questions in the chat to everyone or privately to myself. We will have an opportunity for some Q&A during the last 15 minutes or so, just kind of depending on how the webinar takes us. And then the webinar recording will be posted to our college, which is the Emma Eccles College of Education and Human Services YouTube page.
I don't know. What could it be? What could it?
Okay, and then, so our presenter today is Michael Gerald. He is a first-year assistant professor in the rehabilitation counseling program at Utah State University. Michael completed his PhD in rehabilitation counseling education from the University of Iowa. His primary academic study area is in counseling ethics, and his research has largely centered around ethics and ethical practices in non-traditional settings. In addition to academic training, Michael has been working in the field for the past decade as a human service provider. Michael is currently a licensed mental health counselor in the state of Iowa, a licensed clinical mental health counselor in the state of Utah, a certified rehabilitation counselor, and he also has provided clinical mental health services in crisis counseling, substance abuse counseling, correctional mental health counseling, and also as a private practice provider. Okay, I'm gonna stop sharing my screen and turn the time over to Michael.
Thanks, Dakota, for the introduction and getting everything set up. And I'm sorry again that I muted you. I totally didn't mean to do that. We're off to a rip-roaring start. Good evening, everyone. Again, my name is Michael. Thank you to Dakota, and thank you for the Sorenson Center for hosting tonight's presentation and allowing me to present. Some of you may have noticed I have populated a few things into the chat. Namely my name and my contact information should anybody have any questions or want to get a hold of me. I also included a link to the clinical rehabilitation counseling services at the Sorenson Center. This is a specialty clinic in which I provide mental health counseling services for persons with chronic illness, disability, and developmental disability, as well as problems with substance use disorders and various behavioral addictions. So if anyone is ever interested in those services or has questions or would like consultation, please don't hesitate to reach out to me. We're also looking to expand our services, so there is the potential that here in the near future, Dakota and I will be joining forces, so to speak, to expand the amount of clinical services that we can provide, and eventually we'll also have interns serving in the clinic as well. If anyone has any questions at any point, please feel free to unmute yourself and jump in. Please remember, many of you have used Zoom, I'm sure by now. I cannot see everyone when I'm presenting. And so I won't be able to see if you raise your hand. Dakota will let me know. Dakota will let me know if there's something in the chat. But please don't hesitate to simply unmute yourself and jump in. Interruptions don't necessarily bother me. We will try to leave some time at the end for questions, but I will say that there are over 20 slides. We have about an hour to do this, and I'm not overly confident in my ability to get us to the end and go through all the slides. So if you have any questions, please don't wait until the end. I want to make sure I answer your questions. So I'll go ahead and start sharing my screen so that I can share my PowerPoint. Today we're going to talk about psychosocial adjustment to chronic illness and disability, and I'm going to provide a brief overview. So as you saw in the flyer for the webinar, we're going to be talking about adjustment to chronic illness and disability. I will, as we go forward, provide some, I don't want to go so far as to say tips, but I will provide some helpful information if you find yourself interacting with someone who is adjusting to disability, or if you're just someone who's interested in knowing more about the adjustment process. This PowerPoint is basically collapsing an entire field that studies psychosocial adjustment to disability into 25 slides. So you'll notice that what we'll be talking about will be a very brief overview. There won't be a ton of depth today. So that means if you have questions, if you have specific instances that you want to ask about, please don't hesitate to interrupt and jump in. All right, Dakota, can you see my PowerPoint? It's in, okay, perfect. So our objectives today, I'm going to provide an overview of models of adjustment to chronic illness and disability in order to illustrate, oh, I'm sorry, that says how campers, sorry, may be coping with their diagnoses. I used that slide when I did this PowerPoint for a camp that serves youth and adolescents with disabilities. In this case, campers or clients or family members, friends, yourselves, etc. All of it will be applicable. It's not necessarily meant for that one audience. I'll then provide an overview of common coping methods utilized by persons with CID. I'll then provide an overview of common mental health manifestations related to adjustment to CID. This says that we see at Rally. It could also say that we see in clinical services. As Dakota shared, I've been providing clinical mental health services in the field for about a decade now. And in addition to doing that, my client populations that I typically work with and see are persons with addictions, persons with chronic illness and disability, persons with developmental disabilities. And so I'll be sharing some of those experiences as well. Just a little bit more about me. As Dakota said, I'm a first-year faculty member at USU. I like to joke with people that I was hired off the street, meaning I was hired by USU not from another academic institution. I was hired from private mental health counseling practice in Iowa. I'm currently, in addition to being a first-year faculty member, also a part-time mental health clinician with the Sorenson Center, operating, as I noted, the Clinical Rehabilitation Counseling Center. There's a link for these services in the chat. And if you cannot access the link, please feel free to let myself or Dakota know. If you have questions about the center, if you have potential referrals, please don't hesitate to email me directly, and I can direct you to who can coordinate that. I also identify as a person with a disability. I had my first major surgery at 18 months, and I continue to live with my disability, my medical condition, whatever term or phrase you want to use, and it's a disability that I have to manage every single day. If you're curious, I can later on answer questions about my specific disability and disability experience, some of which I'll be sharing throughout the PowerPoint presentation. One of the fascinating things about doing this research and doing these presentations is I can see myself fitting into these models. I can see myself with these manifestations or exhibiting these coping methods, et cetera, that we'll be talking about. And so I'll share some of that. I don't usually get into the particulars of my diagnosis, only because we only have an hour and it's a long story. But if you have questions about it, you're more than welcome to ask. So I like to share this because it's important to go over previous definitions and terminology related to disability. The reason I say previous is because some of these terms are, although they are still in use in the field of disability studies, in the field of rehabilitation counseling, they are outdated, meaning we don't really use these anymore. Additionally, their definitions are varied, but in the past, when it came to defining disability, these were the three major terms, and they all had distinct meanings. So in the past, we talked about impairment as being an abnormality in body structure or appearance. Disability is any restriction or lack of ability to perform an activity. So the distinction would be the impairment is, for lack of a better phrase, what would be wrong or different with a person's body. A disability would be what would be the resultant functional impairment. What is the thing that they cannot do? And then a handicap is the disadvantage that the individual experiences as a result of the impairment or disability. So the disability, what can't they do? And then what are the disadvantages that a person experiences? That would be the handicap. Again, as you can see, these terms are outdated. They're no longer used. I will say this, though, disability is obviously still in use because it's what we're talking about today. Impairment in the world of mental health counseling is still a term that we use, but it means something different than abnormality in body structure or appearance. In mental health counseling, we talk about impairment in terms of what is the impact on level of functioning, similar to how you see handicap used here on the slide. You'll note we do not use the term handicap or handicapped to refer to persons with disabilities anymore. However, it is still a term that is utilized when you think about handicap parking or a handicap placard that you might have on your license plate. So the term is still in use in governmental or bureaucratic agencies. It's just not in use in the research or the treatment field. As far as what terminology we do use, you'll see it at the bottom here. When we refer to persons with disabilities, we refer to them as persons with disabilities. We utilize person-first language. The reason for that is because it is humanizing, and therefore we also, in some respects, identify that they are a person first, and they are not simply a walking disability, a disability with legs. Now, I will say this, there is some, I don't want to say controversy because it's not controversial. There is some debate, that's a better term. There is some debate in the field of disability studies with regards to person-first language. So do we refer to people with disabilities as persons with disabilities, or do we refer to them as disabled persons? Judy Heumann, who is a famous disability rights advocate, literally one of the first people to lay the foundation for the Americans with Disabilities Act, which took place in 1990, or was signed into law in 1990. Judy Heumann was doing this work in the 60s and in the 70s and was part of a famous sit-in in San Francisco, or in the Bay Area, forgive me, in Berkeley. Judy Heumann, person with a disability, identifies as a disabled person. And the reason being, Judy Heumann will say that if we continue to say persons with disabilities, we are still implicitly acknowledging that disability is a negative label. It is only bad. And therefore, as part of taking ownership of it, she is identified as a disabled person. It is not bad inherently to be disabled, whereas the movement to say persons with disabilities was part of the anxiety around labeling people as a disabled person for the reasons that I was just describing. So what we say as a rule of thumb is we ask people to refer to persons as persons with disabilities, to use person-first language until you find out additional information. So your go-to should be persons with disabilities, and if the client, if the family member, if the friend, if the person receiving services chooses to identify as a disabled person, you can use that language. But your shorthand, your go-to should be a person with a disability. For myself personally, I've used a number of different identities. I'll say person with a disability. I'll say person with a medical condition. I don't technically have a chronic illness, but I do identify as a person with a disability. I haven't really thought too much about being a disabled person, so I'm not sure that I'm quite there yet with Judy Heumann. It's important to understand the psychosocial aspects of disability, as they can help illuminate disability experience, which is often absent in our culture or simply misrepresented. And certainly for those of you who are treatment providers or human services workers, we very rarely talk about the lived experience of persons with disabilities, focusing instead on how to treat persons with disabilities. There's certainly nothing wrong with wanting to treat persons with disabilities to help them improve their functioning, but in doing so, we are focusing primarily on their deficits, and we are losing sight of, again, the lived experience, the more subtle emotional and psychological adjustment that takes place when persons adjust to disability. The term psychosocial refers to the psychological and social understanding of a given phenomenon, or how a given phenomenon affects a person's individual psychological, social, leisure, vocational health, and relational functioning. So basically, we're not just saying that Crohn's disease leads to inflammation of the small and sometimes the large bowel as well. We're saying, well, what does that do? What does Crohn's disease do to employment, to forging relationships, to your psychological and general functioning in life? That would be psychosocial adjustment or psychosocial understanding. So the fundamentals of understanding disability experience largely center around two very broad concepts. The first is, in order to understand disability experience, we have to first acknowledge that disability is universal. This is among my favorite things to talk about when I talk about adjustment to disability, and it's this idea that disability affects every single population, community, demographic. It does not discriminate, so to speak. Persons who are wealthy can still experience disability. Persons who live in countries that have developed healthcare systems can still have disability. Disability affects every single group of human beings. So disability is a universal human experience. And certainly when you look at the literature, disability is among the oldest sources of discrimination and ostracization in human society. So disability is universal. The other component of understanding disability experience that I would argue is fundamental is understanding that in our culture, in our society, and frankly, when I say our, I'm talking about Western American society, not only limited to us, but by and large in our culture, normalcy is the ideal. And whether we admit it or not, we all have schema related to what is normal versus what is abnormal. It is considered to be normal to be ambulatory. It is considered to be normal to not talk to yourself because you're responding to hallucinations. The ideal in our culture, again, whether we want to admit it and say it or not, is normalcy. Now, that obviously means a number of different things. Part of the disability rights movement has been critiquing, and disability scholars in disability studies has been critiquing our ideas of normalcy, which often are abnormal. Easy example of this that's not necessarily disability related is when you look at images of supermodels. I'm thinking back to like the 90s when being rail thin was popular and important among models, and there was this idea that that was the ideal, when in reality it represented a very, very small a small sample of the population, but it was still the ideal. And similarly for disability, even though disability is pronounced in our society, there are millions of persons with disabilities. They are certainly not such a small group that they can be overlooked simply. We choose to ignore that as being abnormal. We say that that is not normal, even though it is a fundamental, universal part of human existence. In fact, there's a term that disability rights advocates will use for persons without disabilities, TABs, or temporarily able-bodied, with the idea that as much as we don't like to talk about disability or acknowledge it as a normal part of life, all of us will experience disability as we age. We will lose part of our hearing or our hearing altogether. We will lose our vision. We will slow down in our ambulation. We may require the assistance of a walker or a wheelchair, etc. So we all will experience disability at some point, despite our social value that normalcy, aka able-bodied, is the norm and is the ideal. Additionally, there's often a conflation of the concept of normalcy with idealized versions of ourselves, which I was just describing, often creates standards of normalcy that are seemingly unachievable for everyone, yet the mere absence of a disability can allow someone access to normalcy. So even if someone doesn't have, again, the perfect body or the perfect physique, if their body is without disability, they can still access the standards of normalcy. They can still pass or fit in with regards to being normal. So that's important because that means then that much of the experience of disability is socially constructed. So barriers, difficulties, and reactions to disability that hinder adjustment to disability are often social constructs. Disability is not an inherently negative experience, but disability in the context of a society that values normalcy as the ideal and that is primarily constructed for persons who are able-bodied is one that creates barriers to adjustment to disability. Again, please feel free to jump in if you have questions or comments. I realize I'm hitting you with a lot of information here early on. So there are models of disability. I'm going to highlight 3. There are actually 2 others that I'm not highlighting here, only because we don't have time or the space, but I'm more than happy to talk about them. 2 that are not here are the functional model of disability and the environmental model of disability. The environmental model and the social model actually were heavy influences on the Americans with Disabilities Act, and the functional model is a major influence on vocational rehabilitation services. So simply for the sake of time, I decided to exclude them, and I wanted to focus on a few that are really important. I'm actually going to start with the medical model because it's actually the foundation for most human services. Actually, I would argue all human services for persons with disabilities, with the exception of centers for independent living. The medical model is focused on medical conditions within the individual, and the goal of treatment is to treat or cure the condition using medicine, surgery, or other treatments, cognitive behavioral therapy, something like that, in order to basically eliminate the disease, the abnormality, the issue. We try to remove it in order to reduce symptoms and improve functioning. A surgeon cuts, a prescriber of medication prescribes. We are trying to get rid of disability. It is viewed as a problem to be excised. In fact, there's a quote, it's an old quote in medical history or the history of the field of medicine, in which a medical provider basically says that the body is like a battlefield on which we wage war. So we're fighting this disability or this illness in order to help this person. So there's nothing really wrong with that. But as you can tell in the quote that I just shared, that means then that for persons with disabilities, their bodies are not necessarily treated as connected to them. When our bodies are perceived to be diseased, when our bodies are perceived to be ill or abnormal or impaired or handicapped, people perceive that they can simply work on them as if you needed to change the oil on a car, as if you needed to make a repair on your RV, that you can just hammer away, you can drill away, and it doesn't really matter because it's all for good. This is really important. I'll just share briefly an experience. When I was, I must have been like 5 years old, maybe 6. I had a laser surgery. So I went in and it was a pretty pronounced laser surgery, and the doctor was a doctor I had not seen before. I had been receiving other laser treatments. I would go in, I would have the laser treatment, I would typically stay overnight and recover and then go home. Well, this one in particular, the doctor said, you know what? And again, remember, I'm a child, I'm very young. The doctor said, I've got a new and more powerful laser. I don't remember, I'm not a biomedical engineer, so I wouldn't be able to tell you what it was. But I remember it's something like a CO2 laser or something that is something that stuck with me. And he, for lack of a better phrase, and I'm sorry for being indelicate, he carved a chunk out of me. There's no easier or better way to put it. He thoroughly messed me up, to the extent that I ended up in the hospital for days after, recovering from a surgery or a treatment that typically was something I went home either that night or the next day. And I remember being a kid, and I remember screaming in the tub because they were pulling gauze out of the wound and it was hurting, obviously. But if you think about the medical model, now this is an extreme example, but if you think about the medical model, that doctor wasn't worried so much about how much pain I would be in, what the recovery time would be. He was more worried about, let's get rid of this thing that we need to get rid of. That is inherent within the medical model. And we have to be careful when we apply it to persons with disabilities, because as you can imagine, it does a very good job of quieting or blanketing the psychosocial adjustment to disability, because the medical priorities are placed at the top. The social model of disability emphasizes social and environmental barriers for persons with disabilities as primary contributors to disability. So the idea here is that if we lived in a society that did not revile persons with disabilities, or it did not revile disability in general, if it wasn't afraid of it or ignorant of it, then we would live in a society that would be more accepting of persons with disabilities, and therefore the lives of persons with disabilities would be improved, because attitudinal barriers would essentially be removed or lessened. The example of this would be if persons with disabilities had been perceived as equal at any time in the history of our country, they would not have been among the last groups to receive civil rights. You know, you think about the fact that persons with disabilities, if you think about the ADA as the Civil Rights Act for persons with disabilities have only had equal protection under the law for about 30 years now, in a country that has existed for over 200. So the social model says if our culture had not rejected persons with disabilities or sought normalcy as an ideal, we would have constructed a society that created more opportunities for persons with disabilities, and unemployment for persons with disabilities wouldn't be so high. Access to healthcare for persons with disabilities wouldn't be so poor, et cetera, et cetera. So the social model basically takes the problem outside of the individual and it puts it into culture and society at large. The biopsychosocial model is a model that we often use in clinical services. This is where we focus on the complex interaction of the social, medical, and psychological aspects of a disability. So if you do like a biopsychosocial intake, you're going to focus on not just the symptoms that may come along with a given chronic illness or disability, but you're also going to focus on the interplay between those symptoms and other parts or domains of a person's life. Disability experience can therefore be boiled down to, and now when I say boiled down, doesn't mean that it's narrow or simplistic, but it's an interaction between 4 domains or 4 factors. Those are developmental factors, environmental factors, personal factors, and social factors. A friend of mine, a good friend of mine, who I volunteer with, and I've known her actually since I was a kid. We used to go to a camp together for persons with disabilities, and I laugh just because it's funny that as a kid, I went to a camp for kids with disabilities. When she was a kid growing up, she grew up in a small town in North Dakota. That small town in North Dakota had stairs. There were no elevators, there were no lifts for her wheelchair, and she's been in a wheelchair her entire life, or has used a wheelchair her entire life. And so she actually could not get down the stairs to the lunchroom. And as a result, rather than make accommodations like installing a ramp or, God forbid, asking someone to carry her down the stairs, a couple people to team carry, she had to eat lunch in basically the teacher's class all through elementary school. And so for her, there were a couple of things that happened there. There was an environmental barrier with regards to her disability, and that impacted her development. It impacted her ability to, if any of us can remember what it was like to be in the lunchroom with our classmates, you know, whether it was trading food or telling inappropriate jokes, maybe that was just my school, or throwing food at each other, getting into trouble. We used to, when I was in elementary school, we used to make concoctions, like food we didn't eat. We would just mash it together and try to bribe someone to eat it and watch how grossed out they were, just dumb stuff. All of that is part of our social development, and this was something that my friend missed out on. Disability experience also comes down to personal factors. These are often referred to as intrapersonal factors or internal factors. What are our own internal resources in how we respond to disability? Am I inherently an optimist or a pessimist? And am I someone who is calmer in my temperament or demeanor, or am I someone who is more quick to anger or just simply be emotionally reactive? That obviously enters the fray when it comes to disability experience. And then social factors. What are the reactions of those around me? I often share this, my family, as part of coping with my disability, my grandparents, who were deeply Catholic, they've both since passed, both were deeply Catholic. And I remember my grandmother used to tell my mom that God had a special plan for me. So in my childhood, when I was sick, when I was in the hospital, there would be days where I would just be, quite literally, I would lay on my parents' bed and play with G.I. Joes and watch movies, because that was where the VCR was. I'm aging myself, but the VCR was in my parents' bedroom, nowhere else. So they would lay me on the bed and I would play G.I. Joes and I would watch movies because I couldn't move. I was too ill to move. I was in too much pain to move. But part of how my family coped with that, and by the way, I'm not suggesting that this is true, but I'm just saying part of how my family constructed their response was to say that this is all this suffering, all this stress is part of a larger plan. The experiences of persons with disabilities are the result of the extent of impairment and disabling, which with respect to disability has to do with a combination of the person's internal resources, their environment, and the medical condition or disability itself. We can't ignore that. That's one of, by the way, I shared the social model, and I want to say very clearly that there was no model that I shared earlier that was superior to another. In fact, one of the critiques of the social model, which has actually even been critiqued by persons with disabilities, including disability rights advocates, is that the medical condition or disability itself does actually have consequences. I just shared an example of, being bedridden to some extent in my childhood, which is why, by the way, I refer to Disney movies as my sick movies, because that was what I would watch when I was sick. That was not because of oppression. That was not because of prejudice. That was not because of scorn or rejection. My family actually was very loving of me growing up. They still are, and were very accepting of my disability. I couldn't move because I was sick and I was in pain, and that had to do with the condition and the disability itself. So we certainly cannot ignore the impact that the symptoms, the manifestation of the disability itself has on a person's experience. The unfortunate reality, though, is that persons with disabilities are often identified in terms of their disability. And what I mean by that, it goes further than simply language when we say that somebody is an autistic, or someone is a schizophrenic, or someone is disabled. We basically boil their personhood down to this singular component of their life. We say they are their disability, and we do that because we perceive them to be different than the norm. We perceive them to, and depending on how you view this and how far you want to go with it, persons with disabilities historically have even been seen as violating the norm. Even though it was potentially through no fault of their own, they were seen as actively going against, as making society worse, whether it be a burden or an eyesore. If any of you are curious, or if some of you may be aware of this, you can go look up the ugly laws, which were laws that were passed predominantly in large cities that made it illegal for persons with disabilities to panhandle, because they bummed people out, quite literally. That they made people sad. They made people uncomfortable. Adjustment and response to disability, it's important, is unique and varied across individuals due to the factors listed above. So don't worry, we're going to talk more about what we mean specifically by adjustment to disability. So these are just some ways that disability can impact development. So this would be much more prominent among persons who experience what's referred to as a congenital disability or a childhood disability, meaning they acquire or are born with a disability during a critical developmental period, typically childhood, infancy, adolescence, etc. That's not to say, by the way, that disability acquired later in life cannot impact development. It certainly can, but usually when we describe disability impacting development, we're describing its impact on the development of children and adolescents. I won't go through all of these for the sake of time, but you can imagine that disability itself can impact achieving developmental milestones. Maybe it's diminished degree of functioning. It can also impact achieving developmental milestones because of limitations due to the disability. So for instance, if you think about something like ADHD, if a child has ADHD and as a result they act out in class or they have trouble sitting still, the teacher might remove them from class, send them to the office, send them outside. That was a big one when I was a kid. You get put outside, you had to go stand outside the door or something like that. Well, now we've taken the child out of the environment in which they are learning, not just academically, but they're developing socially. They're developing with regards to emotional and behavioral self-regulation in the context of the classroom, but we've removed them from that, and that can inhibit development across a number of domains, not just in their academics. I do want to touch on this last one, and that is the presence of disability can lead to persons with disabilities being infantilized. I'm not sure if anyone knows what that means, and I wish we had more time and I would put this out to the group, but just for the sake of time, when we infantilize someone, and by the way, it's not only for persons with disabilities, we do this with women as well, but for persons with disabilities, being infantilized means when people find out that we have a disability or when they see that we have a disability, they treat us like kids. They look at us as children. The friend of mine, her name is Shantate, that I was telling you about, she uses a wheelchair, and as a result of her disability, Shantate is small. She is smaller than I am. She is smaller than a lot of adults her age. She and I are about a year apart. But Shantate is a professional. She has a master's degree. She's a certified rehab counselor. She works with persons with disabilities. But when people see her, they talk to her, not always, but oftentimes, they talk to her like a child. In fact, she'll describe that at the end of her day, she is often most exhausted, not by her work, but by her experiences with ableism. People looking at her with pity, people talking to her with a high intonation, kind of like you're talking to a child. Sorry for that impression. I know that's off-putting, but that is, I've actually been there when people have talked to her like that. I shared this story, Dakota, you'll remember this because I shared this in a presentation just a couple weeks ago, where she and I were at a liquor store and we were hanging out and we were buying liquor. I know persons with disabilities drink sometimes. And she was checking out, and the cashier kindly turned the debit machine towards her so that she didn't have to reach over. That was helpful. And then proceeded to, again, she is an adult woman who's completely functional and independent, lean over it, and as she is swiping her card, he was saying, "Good job. There you go. Good job." As if she had never done that before. And that's because he viewed her not as an adult, equal person, but as a child. And this also impacts persons with disabilities when it comes to sexuality. Persons with disabilities often do have questions and concerns with regards to sex and sexuality. And people often look at persons with disabilities as being asexual, or they may even hope that they're asexual. And this is where you get forced sterilizations. This is where you get people asking for interventions to stop persons with disabilities, developmental disabilities, from masturbating, etc., as if it weren't a natural normative behavior. And all of that has to do with the infantilizing that persons with disabilities experience. When it comes to response to disability or adjustment to disability, there are several models. And by the way, remember, there are more models than this. This is a quick overview. These are just three that are pretty prominent in the psychosocial adjustment literature. The stage model basically follows the stages of grief model that has been proposed for death and dying. Now, it's important to note, though, that that model of grief was actually intended for persons who themselves were dying. It wasn't actually meant for persons who were grieving someone that they are lost. But regardless, it has been adapted as a stage model of adjustment to disability. So when the onset of disability occurs, there is shock, disbelief. That is followed then by denial. Now, this, by the way, can be denial of the entire presence of the disability. I am not a disabled person, or I do not have a chronic illness or disability. I'm denying it altogether. It can also be denial of the extent of it. I experienced some of this when I was a kid, where I would push my body in sports, in athletics, basically to places it should not have gone. But I was in denial of the extent of my disability. I didn't care to take care of my body, because that would then mean that I had to admit that I had a disability, and I didn't want to do that. That stage can then be followed by depression, sadness, feeling forlorn, feeling a sense of loss, grief. That can then lead to regression. Regression is a psychological term that refers to a regression to a prior stage of development, where you might, or how you might see this manifest in persons with disabilities, is feeling like they can't do anything and that people need to take care of them. I can't. I have a disability. That could be an example of a regression. You can even see it, by the way, with persons with disabilities who have acquired a disability regressing to an earlier stage of emotional and behavioral regulation. Maybe now I essentially throw tantrums again because I'm having trouble adjusting to my disability. That's then followed by anger and questioning. Why me? Why did this have to happen to me? And this is then theoretically followed by acceptance. The social moratorium model is where individuals essentially demarcate a separation between their life before a disability and their life after a disability. So that was the old me. This is the new me. Some of the language you'll hear in the social moratorium model will be a new normal. I have to adjust to a new normal. So essentially, the individual is starting over with regards to their identity. Personally, I do not like the social moratorium model. I want to be very careful I say that, because these all exist. I don't mean to endorse or reject any models in particular, but I will tell you as a clinician, this one is one that I see contribute to people not adjusting to disability, because we do not, when we acquire a disability, we do not lose any part of ourself per se. We, in fact, gain, in many respects, new perspectives, new experiences. There is learning to be had when it comes to coping and adjusting to disability. One thing that I will tell clients, and this should clear up social moratorium pretty quickly and pretty easily, when you acquire a disability, your values may not change wholesale. If you value helping others, that doesn't necessarily change when you acquire a disability. It may become more prominent. You may have a greater desire to give back to other persons with a disability. We see that a lot in how the media portrays disability. This person with a disability is helping others, etc. All those things carry over. That's not a new person altogether. Now, the difference is they have a disability now, or a chronic illness, etc., but they are not completely different. So this is why the social moratorium model, for me, kind of sticks in my craw. I don't really care for it. Cognitive restructuring, I will tell you, is something that in the stage model I rely pretty heavily on when it comes to helping persons in clinical practice adjust to disability. Some of the things that we might do, techniques, so to speak, we help people enlarge their scope of values. So they might say, well, I can't do that anymore, even though it was important to me. So we might look at, well, maybe, or how could we look at that value differently so that it does fit into what you can do currently? Maybe that value just needs to be redefined so that it fits the life that you live now, that it fits your current abilities. We also have to, this is interesting, subordination of the physique. We have to help people develop an identity that is not so reliant upon their physical abilities. This is one that I will tell you really contributes to persons with disabilities not being able to adjust, persons especially who acquire disabilities later in life, having difficulty adjusting. And it's because of the importance that we put in our society on our physical functioning, our values that we put on the autonomy that we have with respect to our physical functioning and abilities. And when people lose that, when they lose the ability to move or to do something with their body, they feel like they are no longer a person, or at the very least, they are far less of a person. So when we say subordination of the physique, we say, well, what parts of your life, let's just take that as true, right? That you have lost functioning and you can't do all the things that you thought you could do or you once did. What else in your life is important to you? What other skills and abilities do you still have and that you can utilize and focus on? My favorite example of this is Stephen Hawking, famous physicist, one of the most brilliant physicists that we've ever had in our history, was a person who could not move, who could not even, because of the degeneration that took place as a result of ALS, he couldn't even speak, didn't even have the muscles for speech, and yet still a brilliant scientist. So when we think about subordination of the physique, if Stephen Hawking would have laid down or rolled over and said, it's over, I can't walk, therefore I can do nothing, well, then we would not have benefited from his knowledge. This is just a more in-depth view of the stage model. One thing I do want to clarify, I'm going to talk about the first stage and the last stage. In the shock stage, a lot of people will look at the stage model and say, well, that doesn't apply to people with a congenital disability because they shouldn't experience shock. I can't speak for all persons who have had a disability. Now, a congenital disability means you're born with it. I technically was not born with it. Mine occurred when I was about a year old, but by 18 months was when I had my first major surgery. I will tell you, I still went through a period of shock. When my sister was born, she was 6 years old. Or I was 6 years old, forgive me. And so I had already had my disability for about 5 years at this point. And my sister is born, and I remember asking my parents, or I shouldn't say I remember, they told me, that I asked, when will she have her surgery? When does she get her disability? In my head, we were all the same. Everyone had what I had. There wasn't a difference. I didn't know that there were other children who weren't dealing with what I was dealing with. So there was quite a bit of shock when it came to my disability. It hit me pretty quickly that, oh, I'm not spending the night at other people's houses. Oh, I'm the only one who gets pulled out of class by the school nurse. Oh, I'm the one who has to meet with the teacher, with his parents, before school starts to talk about accommodations. So in that respect, none of that had registered with me as a small child. It took years for that to happen. So I do think shock can happen for persons with acquired or congenital, not just acquired, but also congenital disabilities as well. And then lastly, I do want to talk about the last stage. You'll note that the last stage is referred to as adaptation, change, and integration. So this is not where persons overcome their disability. We don't use that language. We use the term adjustment or respond or integrate or incorporate their disability into their life. And the reason is because we don't want to minimize the impact of disability. We certainly don't want to ignore the impact of disability. We want to understand that adjustment to disability is a lifelong process in which people integrate their experiences into their identity as a person with a disability. There is a final stage of adjustment known as transcendence. I'm not going to go into that too far. Hopefully the PowerPoint will be made available and you can read it yourself. But you'll see here there's a couple of slides that talk about what adjustment to disability in this final stage of transcendence, which is even beyond integration, adaptation, and change. This is where a person might find meaning and purpose in disability. They might seek out new experiences. They might discover new personal strengths. Well, hey, maybe I lost this function, or this is really hard for me, so here's something I can do. My wife experiences chronic pain, and so although it's hard for her to go on a really long hike with me, she can write, and she is a writer. She's published a book. So for her, she has a personal strength when it comes to writing and reading, and that is something that she can do for long periods of time as long as she's sitting in a comfortable position. So those would all be parts of transcending disability. I'm not sure that I love the terminology, but I will say this, the aspects of it are things that I try to get people to in counseling. This is where I want them to go, even if I don't love the idea or the term transcendence. I'm going to skip advantages and disadvantages of stage theory because there are some other slides that I really want to get to, and we're running out of time. When it comes to coping with illness or disability, coping represents a constellation of behaviors that are intended to help an individual manage, tolerate, or reduce stress associated with major life events. So it's important to note that the word coping, by the way, as a mental health counselor, we use this word so much that it no longer has any meaning. But we constantly talk about coping and we never really fully define it. But it's important to note that coping with an illness or disability is neither positive or negative. Coping is just any number of behaviors that someone might turn to, or thoughts, frankly, that someone might turn to in order to better adjust to their disability. Now, again, it's neither good nor bad, which means people can cope in a number of different ways. And in doing so, they may cope in ways that are maladaptive. So in order to cope with chronic pain, I abuse alcohol. Well, I am technically coping, but that's not good for my liver. It potentially isn't good for my social life. It might even impair work. It might get me in legal trouble, blah, 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 blah. We can go on and on. That would be maladaptive coping. So we still acknowledge that it is coping. It's just not helpful. So we don't say good or bad. We don't say positive or negative. We say, is it maladaptive or is it adaptive coping? Is it coping that helps me reduce stress and enhance well-being and functioning? I said earlier that I would push myself too hard physically when it came to sports or athletics, ignoring pain that I was experiencing, ignoring limitations that my body was basically asking me to respect so that I could preserve my body and not make my condition worse. I would argue for me, although people often look at sports as, wow, that's so inspirational, that's so powerful, this person who survived cancer ran a 5K, and it's nothing to take away from that, but we do have to be careful that all coping can be in some way, shape, or form maladaptive. These are typical. I'm gonna actually pause here because we are running out of time. But these are common coping strategies that we see for persons with disabilities. Denial. Denial gets a really bad rap. If you have ever been to a 12-step program, you know that they often hammer on denial and they try to get people out of denial. When it comes to disability, though, denial can actually be, at least for a time, an adaptive response. If I deny the reality of my disability, there's the potential that I can press on, that I don't give up, that I don't concede. I keep trying. Now, over time, it may become unhelpful. It may become, frankly, harmful if I'm in denial to the extent that I'm not adhering to treatment. But if I'm in denial in that I'm not accepting the limitations placed on me by the disability, I might still go to work. I might still engage in my relationship. So for a time, denial can be helpful. By the way, these are not in steps. These are not in order. These are just 5 distinct coping strategies. Regression, I talked about it earlier, reverting to an earlier stage of development. Compensation, you may be hearing this about me with regards to working out or physical fitness. Individuals learn to counteract functional incapacitation in one area by becoming stronger or more proficient in another. This is not always physically related or physically couched. It can also be, like I said earlier, I can't run or walk for extended periods of time, but I can become really, really good at this skill or this ability. And so I put a lot of my efforts and energy in that in order to compensate for functioning that either I lost or I perceive that I have lost. Rationalization, this is when individuals may seek out socially acceptable reasons for their behavior or to excuse themselves for not reaching goals or accomplishing tasks. And then lastly, and this is a really important one among persons with disabilities, I can tell you that from just knowing people with disabilities, also doing this presentation for groups of persons with disabilities, diversion of feelings. So individuals may divert negative emotional states or ideas into socially acceptable behaviors. So I use my anger maybe I'm in that anger questioning stage and I use it for drive and passion to motivate me. Another one is I use humor to cope with my disability. That one really resonates with friends of mine with disabilities. We joke around and make light of a lot. It's not just our respective disabilities, it's also just life in general. It's my wife can attest to this. I make inappropriate jokes all the time. May not even be inappropriate with respect to content, but just timing. And it's because I have grown to make light of situations, to try not to take things so seriously. And that's part of diversion of feelings. It helps me cope with stressors, to think of things in a humorous light. If you are curious, these are some of the potential negative emotional reactions to health conditions. Again, these are negative, so we're not talking about the positive growth-related emotional reactions, things like pride, resilience, self-respect and acceptance. Another one that I see often among persons with disabilities is this feeling of greater empathy and perspective that comes with experiencing oppression or experiencing hardship. So these are just a slide with the negative ones that you may encounter or see. Grief, loss, fear, anxiety, that can be related to other people's reactions. It can also be fear, anxiety related to my condition getting worse or recurring. Anger, depression, guilt and shame, feeling like I'm bad as a person, like I've done something wrong because of my disability. Again, that comes back to violating that ideal or value of normalcy. So I'll stop there. There's only a couple more slides, but I want to be respectful of time and leave time for questions. If there are any, I understand there's only a couple of minutes left. I'm more than happy to stay on if anyone has questions. Yeah, so I'll stop there. Thank you everyone for your time and for listening. And I'm sorry we didn't get through the whole PowerPoint.